Good morning and good afternoon, everyone. Thank you for joining us for the latest iteration of the Center for Global Health's seminar series, Building Effective Global Health Partnerships. This morning, we're joined by Dr. Larry Shulman, who will be discussing his partnership in Rwanda, developing cancer treatment programs in resource-constrained settings, lessons from Rwanda. Dr. Larry Shulman is the Deputy Director for Clinical Service and the Director at the Center for Global Cancer Medicine in the Aberson Cancer Center here at the University of Pennsylvania. He is a practicing medical oncologist with a specialization in breast cancer. He's worked with the late Paul Farmer's organization, Partners in Health in Rwanda and Haiti since 2011. Helping to lead the establishment of cancer programs at both sites. Since coming to Penn, he's engaged in similar work in Botswana. He's also worked with the WHO to update the essential medicines list for cancer. And he's also served on the International Affairs Committee of the American Society of Clinical Oncology. And with that, I turn it over to Larry.
Thanks so much, Alejo. And thanks everyone for joining. I'm going to try to go through a fair number of slides relatively quickly to leave time for discussion, but I'm also happy to have anybody interrupt me along the way. But since I can't see any of you, either send a chat to Alejo or just unmute yourself and shout out. And I'm happy to be interrupted.
Yeah, absolutely. So if you have any questions, please, raise your hand or put them in the Q&A or chat box, which both can be found at the bottom of your screen.
So what I was asked to do was talk a little bit about my own story and how I got into global cancer medicine and the types of approaches that I've taken in my work over the years. Just to preface this, I will say that since I was asked to do this and the time that we're actually talking today, my talk changed a little bit because of the untimely death of Paul Farmer, who's been a partner in this work with me for 3 decades. And I'll come back to that. So I'm going to talk a little bit about our Rwanda program. And this is our hospital, Bitaro Hospital, which is in northern rural Rwanda, in a beautiful area. When we built this hospital in 2011, there was not a single healthcare facility in this area of the country. There really was no healthcare there. To this day, this is nowhere near a paved road or wired internet. We actually use an Israeli satellite for internet. But nonetheless, it serves as the main cancer hospital for all of Rwanda, the entire country. So, it was 50 years ago, over 50 years ago now, that I entered medical school. And in those 50 years, my career has taken lots of unexpected turns, things that I would never have predicted in 1971. And many of them really turn out to be opportunistic. You're presented with an opportunity that you didn't anticipate before. It excites you, and you take that turn. And your interests change over time. And our environment, our medical environment, is so different now than it was in the 70s in so many ways. But change is good. And if I was doing the same thing for the last 50 years, I'd probably be burned out and bored. But over that time, I've done many different things. And I think that's helped to keep me energized, to keep my mind active and challenged. So for those of you early in your career, don't think that you should be doing the same thing for the rest of your time. A lot of what I've done has been centered around patient care. That, in fact, is the most rewarding part of my career, has been and still is, in the privilege, really, to take care of individual patients with cancer. And there's nothing that's given me more of a challenge, but also more satisfaction. But I entered oncology at a time when there really were no structured programs, physical or otherwise. It was really the beginning of oncology. When I started, there were actually no boards in oncology. But I liked the idea of trying to build health systems that supported oncology care And from very early on, from the 1980s on, I had administrative roles that gave me the opportunity to design and operationalize cancer delivery systems at the Brigham in Boston, as Chief Medical Officer at the Dana-Farber, more recently as the Deputy Director for Clinical Services here at Penn in our Cancer Center, and as Director for the Center for Global Cancer Medicine at Dana-Farber and Penn. And when I think back on it, these are five S's, if you will, that Paul Farmer always reminded us of. Really was what I was doing all those decades, thinking about how to staff these units, what stuff we needed to deliver oncology care, what the space had to look like to optimally to deliver that care, what systems underlying that care were necessary, and the social support for our patients. And these, to this day, remain all critical components of how we deliver care, even in a very modern care delivery system. And they have to be focused on the models, have to be focused on safety and efficiency and overall quality. And that's true here at Penn and true in Rwanda as well. My interest in global cancer medicine really did come from Paul Farmer. I hope many of you know about him, and I'll give you some references to him in a minute. But he and Jim Kim and Ophelia Dahl formed Partners in Health in the 1980s. And Paul and Jim were both my interns on the oncology service at the Brigham in 1991, and we became good friends. And Howard Hyatt, who was the former dean of the Harvard School of Public Health, was mentoring both Paul and me and brought us together. And at that time, Paul was working in Haiti, trying to develop healthcare in the Central Plateau. And he would call me up and say, I have this patient, she's a wonderful woman, we've got to figure out a way to help her. One of those patients was a young woman with acute myeloid leukemia who, it's a terrible disease. It's a terrible disease in 2022. To get patients into remission is very, very difficult, even in a place like Dana-Farber or Penn. And I told him, I said, you know, it's really risky stuff. He said, but we got to try. And he flew up to Boston. We put the chemotherapy in a suitcase with detailed directions about how to administer it. And then a couple of months later, I was watching 60 Minutes because they did a special session on Paul and his work in Haiti. And lo and behold, there he is on 60 Minutes with Jolette, who is the woman with acute myeloid leukemia, who had in fact gone into remission and got to be on 60 Minutes, a national TV show, proving that in fact, if you don't think about what your constraints are, sometimes you can accomplish pretty amazing things. This is another story. Claudine was a 12-year-old with osteosarcoma. She was an orphan at the time. Paul found her in a hospital in the East Congo, where she had this swollen, painful knee. He brought her back to the Partners in Health hospitals in Rwanda. She had been traveling around looking for healthcare really for 6 months with the nuns who ran the orphanage. And it turned out that she had an osteosarcoma of the right knee. She had an amputation. She had chemotherapy because she had lung mets, and was in fact adopted by one of our Partners in Health doctors because she was an orphan, brought back to the US for education, both at the high school and the college level. This is her high school graduation picture. And then she subsequently graduated from Wheaton College. But she was a keynote speaker at the dedication of our Protara Cancer Center of Excellence, which I'll talk to you a little bit about, because in fact, she was an example of what can happen when in fact you provide life-saving care. And just as a note, some of you might remember that some time ago, there were tragic bombings at the end of the Boston Marathon, leaving quite a few people with amputations, and she volunteered in the rehab hospital to help them get back to a good life. And here's me and Claudine in 2018 in our cancer center at Rwanda, where she was then working at the University for Global Health Equity. So Paul Farmer, as I mentioned, was an important member of our work, a leader in our work. He died tragically and unexpectedly, actually, at our cancer center in Pataro in February of this year. This is an article from the New England Journal of Medicine called Unclouded Judgment, Global Health and Moral Clarity of Paul Farmer. And for those of you who don't know of him, I would recommend a book by Tracy Kidder called Mountains Beyond Mountains. It's an easy read, but it really helps you to understand why he did what he did and what really the fabric of his work was. And there's also a short documentary called Bending the Arc, which can be found at this website. And I'm sure Alejo could share this with any of you who are listening. These are some quotes out of the article in the New England Journal. One was, there was no trying in Paul's world, only doing. And I can tell you that's true. We skipped the sort of trying part. We just got to the doing part. He believed that if we all could just do a little bit, we would be in a better place. And finally, a quote by Kevin Volpe, who's here at Penn, who heads our Center for Behavioral Economics, said, economists say that people optimize subject to constraints. One of the many things that made Paul special was he didn't accept constraints. And that was true with the young woman with acute myeloid leukemia and many other examples. So we tried to figure out how we were going to do this. And this was, I think, maybe in 2011 at the Columbia School of Public Health, where Linda Fried, who was the dean, invited a number of us to talk about how to develop global cancer medicine in very resource-constrained settings. To my left is Paul Farmer. To his left is Lance Armstrong before his fall, if you will. He was actually one of the major funders for our cancer work in Rwanda. Linda, who's the dean, and Sanjay Gupta, who's a neurosurgeon and a journalist, as you probably know, who is the moderator of the panel. We got help from the Obama White House in helping to fund this and put things together, which was really, I think, very, very important for us in a variety of different ways. But at the same time that we were doing this, there was tremendous skepticism. And that's a lot of what we discussed at that forum at Columbia, where people said that cancer care in places like Rwanda was too expensive, too complicated, and cancer therapy is toxic, and we would kill more people than we could help. And it was very costly, and we should just concentrate on prevention, because a third of the cancers are preventable illnesses from smoking and obesity and other factors. And these are actual quotes from very high level officials in global public health. In 2016, there was a World Cancer Congress in Paris, and I was asked to debate whether we should in fact treat people with cancer in a place like Rwanda. Karen Canfield, who's on the right from Australia, took the negative side. I took the positive side. I always like to remind people that Karen actually believed that we should, but she was assigned to the other side of the debate, and she did her part. There were about 1,000 people in the audience. They had electronic voting clickers. And before the debate, only 25% of the audience, so remember, these are people who came to this global cancer medicine meeting because they're interested in that, but only 25% felt that we should treat patients in Rwanda for their cancer. After the debate, 20% had shifted to 45%, but we're still, frankly, in the minority. And I think it's important to remember that this was the context in which we started to develop these programs. Incredible negative feedback about doing it. I showed this slide during the debate. This is in our cancer ward, our pediatric cancer ward in Rwanda. And I reminded the audience that none of these kids had a preventable cancer. None of their cancers were from smoking or obesity and other factors that they could control. If these kids lived in Philadelphia, their collective cure rate would be about 85%. In Rwanda, when we got there, their cure rate was 0. And though they all look like they're having a great time, if you look carefully, every one of them has an IV in their arm. They're all there for chemotherapy to treat their cancers. And we'll come back to them a little bit later. So the challenge from my point of view in global cancer medicine is not knowing what to do. You know, we have lots of guidelines for a patient with this type of breast cancer. You give this type of chemotherapy or hormone therapy. It's really trying to figure out, in the context of weak healthcare infrastructure, environmental factors, in human capacity, in patient poverty, food and water insecurity, transportation challenges, how to deliver safe and effective cancer care in a sustainable way. And I think we have done that to some success over the last decade in Rwanda. And I'll show you some examples of that later on. But it's really how to do it, not what to do. It's how to do it in the context of these settings. So the principles that we used when we started was that patients should expect accessible, high-quality cancer care for treatable and preventable cancers. That sounds trivial, but they in fact had no access in Rwanda to cancer care at all, no less high-quality cancer care. That the care should be affordable, that poverty should not be a barrier to life-saving care. And unfortunately, it is, and it is frankly in the US as well. There are many places in the US where poverty makes it extremely difficult for patients to access high-quality cancer care. And for many in the world, this would mean that the care had to be free. And all of our care that we provide in Rwanda is free. And I could talk about that a little bit later if we have time. But we have ways of, in fact, supporting that care so that the patients can afford it. Most of the patients from Rwanda would not be able to. And as part of that effort, we have to strengthen in-country capacity. The end game can't be that me and my colleagues go over to Rwanda and provide cancer care. It has to be that we train a workforce there that is skilled and can provide high-quality cancer care going forward. So this is one of Paul Farmer's slides. Says we go, we make house calls, of which I've made many over my years there. We build health systems and we stay. And that we stay is a critical part of that. You can't bounce in and bounce out of these places. I've been going to Rwanda now for over a decade. Before COVID, I went quite frequently. I was there in February of 2020, just before COVID. And we'll be going back again. But again, we use the 5 S's that I mentioned earlier in the talk to help us to design how to deliver care. But a critical feature is ongoing accompaniment. And there's almost no day that goes by that I'm not in touch with my Rwandan colleagues. And they know that I'm there for them basically 24/7. And they know that I've come back over and over and over again. And I have long-term relationships with them, and we built mutual trust. So when I got to Rwanda in 2011, there was not a single medical oncologist in the country. There was no radiation facility in the country. There was one pathology lab where the pathology processing equipment worked 2 to 3 months a year. There was one CT scanner in the country that also broke down frequently and was not always operational. And there was almost no cancer care at all in the country. And the cancer mortality was near 100%. The only people who survived cancer were the people who had the financial resources to go to the airport, get on a plane, and fly somewhere else for cancer care. And what the patients told us when we started to treat them when they came to our cancer center was, we've always known that if you got cancer, you died. And it took us a number of years to change people's concepts of what cancer meant in a place like Rwanda. So we built a cancer center, a pathology lab, and in 2012, we dedicated the Butaro Cancer Center of Excellence. It was the first and really still the only national referral hospital for cancer in Rwanda. Former President Bill Clinton was the godfather of our program, so to speak. He helped get us into Rwanda in the first place. He helped secure a lot of the funding, which allowed us to build the program. And he was nice enough to come with his daughter, Chelsea, to dedicate the Cancer Center with us in 2012. Between Chelsea and me is Agnes Binawahu, who at that time was the Minister of Health in Rwanda, who's been a great partner, and is now the Vice Chancellor for the University for Global Health Equity that I'll talk about later. All the way on the right is Paul Farmer. So we took a very broad approach to developing cancer services. I'm not going to be able to talk about all of these, but it was really from education to risk reduction through diagnostics, treatment, and survivorship and palliative care. And we continue to focus on all of these areas. And it's been complicated and a lot of work, but we've been chipping away at it ever since. Now, I think one of the things for all of us to think about is what is our approach to partnership with a place like Rwanda? And I think this is very important. And this, again, mostly comes from Paul Farmer. But the first is to get in and help in the developing clinical care, infrastructure, health system strengthening as a first object. And that's what we did at Butaro. We built a hospital. We helped to staff it. Our first focus was really on the delivery of care. Once you're doing that, you can develop an educational process, which we've done with our physicians, with our nurses, with our laboratory technicians, with our pharmacists, with other people in the process, because we have that healthcare system that's in place that can be really a nidus of that education. And only after that should we start thinking about doing research. All too often, US or other high-income country researchers have dropped into a country and said, geez, I'd like to study this or I'd like to study that. You know, I got a grant from the National Institutes of Health or the National Cancer Society to study X. I'm going to collect a bunch of patient samples and go back to my laboratory. And while it's important to advance science, that does nothing to improve the outlook of the patients in that country. And I think that has to be our first priority. So this is an article that we published in Nature Reviews Cancer in 2014, so it's 8 years ago, that really talks about what our thoughts and approach were to developing cancer in Rwanda. And it says, the knowledge and tools to cure many cancer patients exist in developing countries, but are unavailable to many who live in the developing world, resulting in unnecessary loss of life. So that is our first challenge, how to bring what we know how to do in Philadelphia to patients in Rwanda. Bringing cancer care to the poor, particularly in low-income countries, is a great challenge, but one that we think can be met through partnerships, careful planning, and a set of guiding principles, which we had, as I've mentioned. Alongside vaccination, screening, and other cancer prevention efforts, treatment must be a central component of any cancer program from the start. There's no reason to screen patients for cancer if you can't treat them when you find the cancer. Sounds obvious, but you'd be amazed at how often that happens. It's also critical that these programs include implementation research to determine programmatic efficacy, where gaps in care still exist, and where improvements can be made. And I'll talk a little bit about that as well. We published this article the following year saying that implementation science for global oncology is an imperative to evaluate the safety and efficacy of cancer care delivery in places like that. I will say Penn now has a Center for Implementation Science. It was created just a couple of years ago, so we're a little bit behind at Penn. But we've realized actually that implementation science is very important to understand the efficacy of care we deliver here at Penn as well as elsewhere. It's critical for us to know whether we can effectively and safely treat cancer patients at a place like Butaro Hospital. We also need to know whether their cancers will respond in a similar way to the treatments that we use in a place like the US. And we now know that cancers that look the same under the microscope genomically are often quite different to different ethnic populations and don't always respond the same to treatments that we use in one group of patients as compared to another. And we're all born with germline polymorphisms. Many of you know about the fact that we metabolize anticoagulants like Coumadin differently depending on those germline polymorphisms, caffeine, and many other drugs. And they differ by ethnic population, and we need to make sure that patients in a place like Rwanda are going to metabolize the chemotherapy drugs that we use in the same way they do, or make appropriate adjustments. And we do this primarily to improve the care that we deliver to the patients, but also we need to prove to governments, to organizations, and the funders that it is possible to successfully treat patients with cancer in places like Rwanda, because we in fact do need the funding, particularly if we're going to deliver care that is affordable and free. This was also at the World Cancer Congress in Paris, and this was a moderated session I did with Dr. Cyprian, who is on the right, who continues to be the director of our cancer program at Pataro Hospital. And we were asked to talk about the essence of a US-Rwandan collaborative arrangement. And what Cyprian said was it was the ongoing accompaniment and the patient outcomes that really mattered in our partnership. And at the end of our discussion, he said that the only measure of success is patient survival. We can't improve the outcome of cancer patients in Rwanda, then in fact, we're not accomplishing anything. And we hold that to be true to this day. So a couple of examples of that. This is a young boy on the left, Fabrice, who at the time this picture was taken was 4 years old. He was actually on the wards when President Clinton was visiting and got to meet President Clinton and Chelsea. And he had a cancer called nephroblastoma or Wilms tumor. This is taken incidentally outside of our pediatric cancer ward with many of the other cancer patients who were there that day. This is Fabrice when he was 4 on the left with his mom. He had inexpensive chemotherapy and surgery. And on the right is Fabrice 4.5 years later at a clinic visit with his mom and his younger sister. He's a healthy, thriving young boy. He's a delight. He's smart. And I'm sure we'll have a long and productive life. I always make the joke, which I didn't realize when I put this slide together, that he's actually wearing the same shirt in both pictures. And he probably has 3 or 4 shirts, and he always wears his nicest one to the clinic visits. So we studied how we had done in treating nephroblastoma in Rwanda. We used International Society of Pediatric Oncology guidelines to treat our patients there. We published this in the Journal of Global Oncology in 2016. We have an updated manuscript currently under review in the same journal. And almost all of our publications have a flow sheet like this that tells you exactly what happened to every patient who we saw with this disease at our cancer center. And the details of this are not important other than to say that we follow every one of our patients. We understand what happened, why things went well or not. And sort of the center of the slide at the top, this says 4 deaths. Those were patients who died before they ever got treatment. They were so sick when they came to our cancer center that we were unable to treat them, and they succumbed to our cancer. We lost some patients to follow-up, and so on and so forth. But at the end of this study, 59% of the children were alive and free of their cancer. A few years before that, it would have been 0. If these kids lived in Philadelphia, it would have been 85%. So we've gone from 0 to 59. We're not at 85%, which is where we should get to, but we continue to try to close that gap. Breast cancer is actually the most common cancer that we see at our cancer center. And this is a study that we did looking at why patients came into the cancer center with such advanced disease. And if you ask many famous senior people in global health, they'll say, oh, it's the patient's fault. They're not smart enough to know that they're developing breast cancer. They don't come from medical care until it's very advanced. The onus is really on them. But when we studied this, it turned out that actually was not the case. It was the health system that was failing the patients. The patients came into their local health centers with relatively early stage disease. The people who were manning the health centers, the nurses and the community health workers, were not trained to recognize breast cancer, which is easy to understand because there was no cancer treatment when we first got there. But it was really the health system that was failing these people, and it wasn't the patient's faults. And we've, with funding from the Breast Cancer Research Foundation, in fact, started to train our colleagues in the community health centers, and we've already seen a major shift to earlier stage breast cancer, which is much more curable just by helping them to understand how to recognize this. And so, like with Wilms tumor, we studied our breast cancer patients. We studied our ability to give chemotherapy, and the details of the slide are not important other than for the bottom line, which is that we were able to deliver chemotherapy at the same high quality rate, on time, at full dose, equivalent to what we do at Penn or at Dana-Farber. This was a study done by one of our residents who went on to become a medical oncologist later on. Again, flow sheets that show you what happened to every one of the patients who came into our center, and survival curves. And the follow-up is very short because we've only been doing this since 2012. But our survival stage for stage are not a lot different than they are here in the US. So these are three articles that I just wanted to mention. One, I published with Yehuda Marte, who was a young faculty member here at Penn in medical oncology, Agnes Binawahu, who at the time was the Minister of Health, that said affordability of cancer drugs in sub-Saharan Africa affects the pricing on needless loss of life. And what we pointed out was that many of our cancer drugs were unaffordable to us. I buy all the drugs for our cancer program in Rwanda so that we can provide free care, but I do that with philanthropically related dollars, and I can't afford a lot of very, very effective drugs that would help us push the cure rates to higher levels. So we have patients who die in Rwanda who, if they lived in Philadelphia, would survive if they had access to these very expensive drugs. We also have to learn how to prioritize the care that we deliver, since we have very severe resource constraints. Some of you may remember that early on in the COVID pandemic here at Penn and elsewhere in the US, we had a lot of healthcare constraints. We closed the operating rooms. Our hospitals were full of COVID patients. We didn't have room to take care of our cancer patients in the usual way. And some colleagues and I wrote this article, Applying Lessons Learned from Low Resource Settings to Prioritize Cancer Care in a Pandemic. And in fact, we used many of these principles to help us to design alternative pathways for cancer care here at Penn. And people use that elsewhere as well. And then finally, recently we published an article entitled Reconceptualizing Risk-Benefit Assessment of Novel Cancer Therapeutics to Expand Global Access and Reduce Worldwide Mortality. And unfortunately, the way that our legal system and our pharmaceutical partners think about things is the concept of do no harm means if you're not absolutely certain that you have all the checks in place, you shouldn't give a cancer drug. And in Rwanda, we don't have the ability to deliver cancer with quite the same support services that we have at a place like Penn. And so they don't want us to use them. But I can show you the decrement in survival by not giving them. And what we say here is that doing no harm includes not doing something as much as doing something and having harm from doing that is. And we've been trying to change the dialogue here, and we are starting to make some progress to get some of these drugs into places like Rwanda. We never want to act recklessly, but we also want to provide, in as safe a way as we can, life-saving medicines to our patients. And this is a chart that you can't read, but again, it sort of goes into how we manage things. We have very limited radiation access in a place like Rwanda, and we can't send all of our patients who need radiation to radiation. So this is an article that's actually under review, but it shows what the overall survival rates are for lots of different cancers with and without radiation. And we use this chart to decide where radiation is most important in helping to improve the overall survival rates of our patients. It turns out, to a large extent, that's with patients with cervical cancer, because I can't send all of our patients for radiation every month. And we have to make very, very difficult choices of who's going to get the radiation, who's going to have a chance to survive their cancer. And that's pretty tough. And this is an article that we wrote a couple of years ago on moral distress and resilience associated with cancer care priority setting in resource-limited context. And I will say this played out in the US as well early in the COVID pandemic. But this is something that our doctors and nurses live with every day at our cancer center in Rwanda, making choices based on what they have and what they don't have, and how to try to help as many patients as we can, the most we can, but knowing that we can't do it at the same level that we would like to be able to do it. And it's really, really hard, and something that we need to continue to struggle with and help our colleagues with. So just a couple of last comments. I mentioned improving education, human capacity, and we built the University for Global Health Equity largely with dollars from Partners in Health, which was dedicated in January of 2019. And here's President Kagame and Paul Farmer cutting the ribbon to open the University for Global Health Equity. It has a medical school, which we're now deeply engaged with from our Penn colleagues. And actually this summer we have Penn medical students who will be going there to work at our cancer center and be paired with medical students from the University for Global Health Equity, Rwandan medical students. This is the university. It's now a little bit bigger than this. I took this the last time I was there, but construction has continued. This I took from the porch from our hospital, so it's right across the valley from Butaro Hospital. I wanted to mention this article. This was a task force, a national task force that we had from the American Society of Clinical Oncology, where we outlined how global cancer medicine can be an academic career. We've now proved this with people like Yehuda Marte and Survey Grover and other faculty members at Penn. We work with the national accreditation societies like ACGME to make sure that they, in fact, were on board and support global training programs. And this has been a roadmap for how places like Penn can, in fact, develop global cancer medicine as an academic career. I wanted to show this picture for a couple of reasons. One on the left is us on rounds quite a few years ago. The woman on the left in the white coat is Alex Vinograd, who's now here at Penn in pediatrics, and a number of the rest of us making rounds there. In the middle is a selfie that Paul Farmer took with a young patient with an osteosarcoma. And he took this 2 or 3 days before he died, and he emailed my son and me this picture to remind us that the person he was asking us about is a human being who deserved as much as we could give him to try to help him to survive his cancer. And on the right is my son, David, We were outside of the cancer ward at Rwanda at Butaro Hospital. When he was a medical student, he spent 2 stints at our cancer center in Rwanda. He's now a pediatric oncologist at Dana-Farber, and he's the main advisor for pediatric sarcoma patients. And so it was Paul who was reaching out to him to try to construct a treatment plan for the patient who's in the center of the slide. And I show that basically to show that this is what can happen with our trainees who can come back and support the work that we do in these countries. And then a quote from Paul in one of his books, it says, "With rare exceptions, all of your most important achievements on this planet will come from working with others, or in a word, partnership." And I think this has been an example of that, and a relatively successful example, but I think it's always important to remember that it's a partnership that does this. And this is my final slide, which is taken a couple of years ago before COVID, during one of my visits to Butaro, and this was our cancer team, that we scurried out of the hospital for a quick photo. A little bit to my left is Christina Hanna, who at the time was a Penn Med Peds resident, is now a fellow in pediatric oncology here at Penn. And some of my other colleagues, Dr. Cyprian all the way on the right, who's our director of cancer medicine. So I'm going to stop there, and I'm going to stop sharing. So I'm happy to answer any questions or hear any thoughts from anybody who's been able to dial in.
Yeah, thank you very much, Larry, for your presentation. That was really informative. I had known about your work with Partners in Health and your work in Rwanda, but not to the level and degree that you had described. So greatly appreciated. As Dr. Shulman said, we're open for questions. If you have any, please place them in the chat or Q&A, or if you'd like to unmute yourself, I can do that for you as well. Give it a moment. So I'll let folks think about their questions. So I have a question, Larry. Oncology is expensive, as you've made highlighted in your presentation. My question is really, what is the long-term sustainability of this? You had mentioned private philanthropy. Is that the ultimate funding that you have, or is there some type of mechanism, either internationally, from WHO type of orgs, or even the government of Rwanda?
Yeah, so that's a critical question. For HIV and TB and malaria, there was the Global Fund, which raised tens of billions of dollars, literally, that allowed us to provide HIV care, TB care, malaria care in the poorest places in the country, in the world. And we don't have a global fund for cancer medicine. I'm not sure we're ever going to have one. But there are a couple of things that I think are worth thinking about. Rwanda is a relatively poor country. They have limited resources. They need to decide where they're going to spend their dollars for the maximum benefit. In healthcare, a lot of that, not inappropriately, has been in maternal child health, has been in infectious disease, has been in trauma, major, healthcare issues that they've been very creative and have accomplished a lot of things. But the reality is that over the last decades, cancer has become one of their leading causes of death and premature death, kids, young adults. And they're starting to realize that this is the case. Part of that is because of our success at treating infectious disease and improving the life expectancy of people so they live long enough to get cancer. But they're starting to realize this, and a lot of what I do when I go to Rwanda is to meet with the Ministry of Health and talk about this. So I think we will start to see funding from that. The World Health Organization is working on helping support cancer care. On Saturday, our Penn medical students had a 2-hour symposium, and the keynote speaker was Andre Obawe, who's a surgical oncology colleague who's working at the World Health Organization. He outlined a lot of their activities, and that's starting to gear up. So I think that there are some paths forward. I will, though, say that a number of years ago, one of our students in her PhD thesis looked at the cost of cancer care at Bataro, at our cancer program there. And there's a lot of things that are less expensive there. You know, a nurse's salary there is about a tenth of what it is here. You know, the overall operating budget for the hospital is much less than it is for the new pavilion at Penn, to say the least. And so her calculations, which included electricity, janitors, meals, surgery, chemotherapy, nursing, doctors, to cure that young boy with Wilms tumor, who I showed you earlier, is about $1,400 US dollars. Now that can be like, you can think that's a lot, or you can think that $1,400 to save a child's life is a pretty worthwhile investment. It certainly is from my point of view. So, you know, it is complicated. It's not trivial. We keep working on it, but I think that we'll get there.
Thank you for that. Again, I'll open it to the audience. If there's any questions, please don't hesitate. I don't want to take everyone else's time. So I do have another question. So you had mentioned, you know, basically your triad of how you're building and how you engage partners. You know, you first start with entering in, asking the questions, building that capacity. I'm curious about the second step, which is the education. You talked about the global health university there that they're building. Could you provide a more detailed update about those efforts and how they relate to the training of medical doctors and practitioners, not only for oncology, but more broadly for the country and the health system there, and how that ties into sustainability efforts, I guess.
Yeah, I mean, that's really a critical question. And, when we got there, as I mentioned, there were no cancer specialists in the country. So there's nobody to educate the residents, the doctors, the nurses, the community health workers. And so we were really starting from scratch. And in the year and a half between the time that we started and the time we opened the Cancer Center, we provided intensive educational sessions in Rwanda. We had a full-time U.S. oncology nurse there from March of 2012, continually until March of 2020, when at the beginning of the pandemic, we brought them home. But much of the cancer care which is true at Penn as well as in Rwanda, is delivered by nurses. It's a highly skilled activity, and we started building that right from scratch. We had radiologists spend huge amounts of time at Bataro teaching our clinicians to do ultrasound-guided cord needle biopsies to make diagnoses. When we opened the pathology lab, we had taken 2 of our very bright technicians to Boston twice to study at the Brigham in their pathology department. And by the time they finished that, they were as good as any technicians, I would say, in the US, and processing our pathology specimens extremely well. But we had no pathologists because there was only one pathologist in the country. So we set up telepathology, and all the pathology was read by pathologists in Boston. And that went on until we, in fact, were able to train a pathologist in Rwanda, trained by US pathologists. But he's there by himself. And at Penn, if you walk into the pathology department, our pathologists, who are great, are continually asking each other for advice to look at these slides, help us with this diagnosis. He had nobody to turn to. So we did continue the telepathology, and he can email a US pathologist and say, I'm having trouble with this case. Can you take a look at it with me? So, we have telesupport for ultrasonography and other radiology. Before COVID, we had faculty and residents going over pretty continually to do on-the-ground training. We switched a lot of that to virtual during the pandemic, but that's now going back to in-person. But we did establish the University for Global Health Equity, which was totally funded by Partners in Health. It is early on in its lifespan. It's 3 years in, most of which has been during COVID. But our future leaders are there. The medical students are there. They're rotating through our cancer wards. We now have, our U.S. Educators there, as well as excellent Rwandan educators. So it's continually been this partnership over many, many years, but you can't bounce in there and give lectures for 4 days and leave and expect a good educational outcome. It's an ongoing process.
Yeah, absolutely. And that kind of leads me into my next question about the long-term vision of what you see, because many folks in public health and global work, they have this idea that sustainability, the end goal is that we're building the capacity of our local partner, so that one day, it's not you or I that is manning, those stations and those clinics, but we're still there as a partner, right? Like you mentioned, if you need to call me up, I can, assist with what you're doing. So how do you envision that? What is the long-term strategic goal? I mean, that sustainability component, again, eventually you have to turn the reins over to your colleagues there in Rwanda, and still provide that support when needed. So how do you view that long-term goal?
So it's a process, and in 2012, they still, in spite of a year's worth of education, had very little expertise in cancer care. Now they're actually pretty good. They're not totally independent. We still play a role. But over the last decade, we've trained more and more people to become expert at all levels: physicians, nurses, community health workers, lab techs, and so on. And their expertise continues to grow, and their day-to-day reliance on us continues to shrink. And that's a good thing. And that's, in fact, to some extent, what carried us through the pandemic, when we were able to, I think, continue to deliver very high quality care, in spite of the fact that none of us were there on the ground. We do have a weekly conference every Thursday morning at 7 a.m. Eastern time, which is in the afternoon, as they're finishing inpatient rounds at Bataro, where U.S. experts and our colleagues in Rwanda go over the tough cases, talk about things, and there's frequently attached to that sort of a mini lecture, if you will, using what we call echo technology, which was developed in the U.S. to help with remote learning. We actually sent our team down to Houston to be trained at MD Anderson in their echo technology. We use that on a regular basis. So there's case discussions about the difficult case on the boards that day, but also focused educational processes. That happens every day, every week on Thursdays at 7 a.m. Is well attended. And it got disrupted a little bit, the very early aspects of the pandemic, when we were all scurrying around trying to figure out what was going on and how to deal with it. But very quickly, it was reinstituted, continues to go on unabated. But it's a process, and they're so much more independent now than they were 10 years ago. We still play a role. And here at Penn, it's no different. Senior people help the junior people to grow. And as I often tease people, my boss, who's Bob Vonderheid, who's the Cancer Center director here at Penn, was my trainee 20 years ago. So be good to your trainees because you don't know when they're going to turn around and be your boss.
Absolutely. Thank you very much, Larry, for that clarification. And just one last question. So, as Rwanda has, progressed in the independence that they've, gained through your mentorship, as well as, the support of Partners in Health, is there like a threshold or a level of, self-sufficiency that you would be comfortable with, and your other colleagues would be comfortable with, so that you do, primarily just, you're here in this supportive measure, and then start focusing these efforts and maybe potentially trying to replicate or model what the work you've done in Rwanda, it's say in Haiti, and focus more in Haiti, or another country where cancer care is negligible to non-existent.
Yeah, so I think that's a great question, and I have two answers for it. One is that I'm not sure we want complete independence, right? That there's some benefits to continual interaction, and that's true for all of us in the U.S. So in a couple of weeks, I'm going to go to Chicago for the annual oncology meetings, which are actually going to be held in person, we think. And I do that to learn from my colleagues and from them to learn from me. I don't practice completely independently here in the US. We're always working with each other in shared learning. At all the 6 Penn hospitals, the cancer programs are reviewed every 3 years by an outside organization called the Commission on Cancer, which I actually used to chair. But it's a national organization that comes in and reviews your cancer program and tells you where you could do better and provides you with data to show you that. And my point of that is that at Penn, we rely on outside help. It's important to not be, arrogant about your self-sufficiency. We all learn from each other. It's always good to have another set of eyes on how you're doing. And collaborations with colleagues, even within the U.S., is very, very helpful and productive. I would never want to sit here and practice in total isolation at Penn. And they're not going to want to do that, I don't think, in Rwanda as well. We learn from each other.
Yeah. I guess my question was more of, there's a less reliance on folks like yourself, or others coming there, and absolutely, definitely, medicine is a community and a collaborative practice, and definitely you learn when others are observing and can give you feedback.
They're much more independent and self-reliant now than they were a decade ago, and every year they're more so. There are now actually 5 oncologists in Rwanda. When I got there, there were none. We've helped to get all of those people trained. They're much more reliant, self-reliant than they are now, and it will continue to be more so that way.
All righty. Well, thank you very much. We are approaching time. So if there's any last minute burning questions, feel free to place them in the chat. While you're doing that, I just want to give a programming update. Next Wednesday, we will be joined by Dr. Brianna Parsons from Penn Vet. Instead of our normal time from 9 to 10 a.m. Eastern, that presentation will be held from 12 p.m. to 1 p.m. Eastern Standard Time. And a full list of any scheduled changes can be found on the Center for Global Health's website. And with that, I thank you very much again, Larry, for joining us this morning. And I'll let everybody else have a great rest of the day. Thank you.
Yeah, thanks for having me, and I'm happy to have anybody reach out who'd like to continue the conversation.
Yeah, absolutely. I can share that contact information with the folks who joined us today.
Great. Thanks, everyone.
Thank you. Bye-bye.